All right, morning everyone. Thanks for having me. Oh, my screen is on black here. Is there a way that I can get my screen back here? All right, well, my name is Alex. I'm one of the current AGY4s here at GW. I am going to wash you for joints in August 2025. That's okay. Okay. All right. Yeah. And today I'm going to be talking about can hip and knee arthroplasty surgeons help address the osteoporosis epidemic. I want to take just this time to acknowledge my co-authors, specifically also Dr. Harris, who's sitting in the audience as well as one of the faculty mentors, Dr. Sterling. And we have nothing to disclose. And so studies have shown an intersection of osteoporosis and those undergoing lower extremity arthroplasty for osteoarthritis, with the prevalence of osteoporosis in the population roughly being about 26%. And in addition to the increased risk of fragility fracture, these patients now are at risk for periprosthetic fracture. Similar to the general population at risk for osteoporosis, routine screening via DEXA scannings is in the those undergoing total joints is alarmingly low. And so in a single institution study of 200 total joints patients, 60% met the criteria for DEXA testing, but only 18% actually had undergone testing within 2 years before surgery. And in a similar study, in a study of 505 total joint patients, 88 patients did not receive routine screening, although it was indicated. And so although this is interesting, these studies are limited to a single institution and may not be extrapolated on a national level. And so we have 3 aims for our study. First one being proportion of total joint patients who met at least one criterion for osteoporosis screening, aka high risk. Proportion of those patients who underwent screening, and then 5-year cumulative incidence of fragility fractures and periprosthetic fractures following total joints in a diagnosis treatment naive patient at high risk and at low risk for osteoporosis. So in classic fashion, we use the ProViral database, and we basically include patients who underwent total hips and total knees. In order to make a more unified cohort, we had these 5 exclusion criteria, and then afterwards, we stratified by patients if they are high risk or low risk. And this high-risk patient population criteria is actually established by the American Society of Endocrinologists. And basically, if you meet any of these criteria, you are warranted to have a DEXA scan according to them. For statistical analysis between high risk and low risk, we use a Kaplan-Meier as well as a Cox proportional hazard ratio model. And I apologize, it's a busy slide, but this is our initial baseline parameter. So in the total hip cohort, you have 380,000, and the total knee cohort, you have 795,000. But if you look, 53% in the total hip criteria and total knee criteria, roughly 55% in the total knee criteria, met a criteria for any high risk. However, when you look at that criteria specifically, so you have 201 in the total hip group and the 439 for the total knee group, only about 12 or 13% actually had a DEXA scan. When you look at the 5-year outcomes over here for periprosthetic fracture and fragility fracture, just looking at broken down by total hip and total knee, across the board, you're going to see an increased risk in periprosthetic fracture and fragility fracture for our high rate group, looking at 1.6, 2.06, 1.55, and 1.78. So our study found that treatment diagnosis naive total joint patients, 50% met at least one criterion for osteoporosis screening, showing the high demand for screening in this population. Additionally, it found an alarmingly low screening rate of 15% in high-risk patients, showing that the role of surgeons can play potentially in screening patients. Lastly, it shows that high-risk patients were approximately 1.5 times as likely to have a periprosthetic fracture and 2 times as likely to have a fragility fracture within 5 years of a total joint. And a significant difference largely suggests that there are most likely patients with occult osteoporosis in the higher risk patient population that were not routinely screened, further supporting the demand for hip and knee arthroplasty surgeons to initiate the bone health screening. And just to really take the point home, these are the numbers magnified, but given our results, you have programs like Own the Bone who have increased awareness in the United States. However, clearly the work continues, and we can all help. Thank you.
Next, we have William Jones from Thomas Jefferson.